Hi, welcome to the Retirement Education Center of North America. Today's topic is Medicare. As you may know, Medicare can be like trying to walk through a maze. Okay, presenting today is Peter Stoner, and Peter is a Medicare knowledge. Peter is Medicare knowledgeable and has over 20 years of experience helping people through the Medicare maze. Right? Peter works with all the major insurance companies that offer Medicare supplements. He works one-on-one with individuals and is an informative educator in the area of Medicare, speaking publicly and privately in groups and organizations. Peter, welcome.
Thank you. Thank you very much. And welcome, everyone. We're going to talk today about Medicare 101, so it's kind of the basics of Medicare, if you will. The first thing I always like to stress is that what we're talking about today is going to be for educational purposes only. That's to say, it's not a sales presentation. I'm not going to talk about specific plans. This is very important as far as Medicare is concerned. They have the oversight over Medicare, and they want to make absolutely certain that we're not turning this into a sales presentation. It isn't. It's educational. My approach is to try to simplify the process. So I believe that when somebody is turning 65 or when they're about to retire, they get inundated with literature. And as a result of that, it becomes very confusing, virtually overwhelming. So what I try to do is to simplify the process so that it makes sense, so that people can make informed decisions based on information that's been provided for them, based on their specific needs. So what are we going to learn today? We're going to learn what is Medicare and how does it work? How can you enroll? Most importantly, when can you enroll? So most people know this is the time of year, if you're already on Medicare, you can make a change. So every year between October 15th and December 7th, anyone who is already on a Medicare plan can change that plan. So they're not locked in. A lot of people think, gee, if I join whatever, I'm going to be locked into this plan for the rest of my life. That's not true. It can be changed every year. So the other thing that we're going to deal with that's of utmost importance is, so what are the options available in addition to Medicare? But I want people to understand when the seminar is over, that once they become eligible for Medicare, and when I say eligible for Medicare, I mean that they have both Part A and Part B. They have one of two options. They can either go, and think of it as a V in the road, if you will. You can either go one way to a Medicare Advantage plan or the other way to a Medicare Supplement plan. So those are going to be your major options once you have Medicare. I use the analogy of a maze when I talk about Medicare because mazes were developed thousands of years ago, and right from the beginning they were designed specifically to confuse. Now I'm not implying that that was the genesis of Medicare, that it was designed to confuse, but when you think about it, it was happening in a political setting. It was involving politicians, lawyers, bureaucrats in committees. You know, that's not a real fruitful combination necessarily. And it's primarily because they had different goals in mind. I'll give you one example. So Medicare was introduced in 1964. That's when the legislation was passed. Actually took effect in 1965. And one of the primary things that was going on in the country at that time that we tend to forget or we tend to overlook is that there were a number of hospitals in the South, primarily, that were still segregated. So one of the first provisions of Medicare was that we will not pay hospitals that are still segregated. And lo and behold, in very short order, because of the Medicare money was so rich, the hospitals in the South that were segregated dropped that provision so that they could get the Medicare money. So a little bit about me, my experience. I've been involved in Medicare sales for 26 years, since 1994. For a while I was for over 10 years actually, I was the employer group retiree sales manager. That's the person within a health plan who focuses on providing Medicare products to the retirees of large employers. employers like a Raytheon or a GE or the GIC, which is the Commonwealth of Massachusetts, and so forth. These are very large employers. And, fast forward all these years later, and a lot of those employers now are no longer applying or providing retiree coverage for their retirees. But municipalities typically still are. So I'll get calls from time to time from people whose spouse worked at a municipality, a teacher or whatever, and they find out that they are offered health coverage through the town. And usually those plans are richer. When I say richer, I mean they have greater benefits or less cost than the kind of Medicare plans that you can get on the open market. So after I finished up that stint, I became the Director of Medicare Sales at Fallon, which is another health plan here in Massachusetts. And I've been providing brokerage on Medicare since 2013. I'm joined by someone who I met at Tufts Health Plan. We're not a couple, she just works with me. She is focused on primarily the provider organizations that do Medicare plans. So for example, if somebody calls me and they're interested in a Medicare Advantage plan, I know that Medicare Advantage plans all have some form of a network. So we need to look at those networks very carefully to make sure that they're a good fit for somebody. Kathy does that. The other reason why I'm pleased to be working with Kathy is typically the first thing that we do is that we look at somebody's prescriptions. We do that because that's one of the large cost variables under Medicare. So sometimes a man would prefer that a man look at his prescriptions. Sometimes a woman would prefer that a woman look at her prescriptions, primarily because there's some sensitivity involved in that. And I like people to know that we are able to accommodate that. So what is Medicare and how does it work? I think most people understand that Medicare is for those who are 65 and older. So most of the time, somebody becomes eligible for Medicare because they're turning 65. There's a little confusion over, gee, is it 62 or 65? 62 is when you can become eligible to take Social Security. 65 is when you become eligible to take Medicare. Now, just because you're eligible to take it doesn't mean that you have to take it. So there's a lot of people who continue to work after becoming 65. They don't have to take Medicare if they choose not to. The other group of people that are eligible for Medicare are those who are under 65, but they have some sort of special needs. So this could be a relatively young person, or it could be somebody who has been designated as disabled for at least 24 months. Some of the things that Medicare does not include, however, is it does not include a maximum out-of-pocket. So your costs are not capped under Medicare. Essentially, the sky's the limit. So if you were to be hospitalized and you didn't have anything but A and B of Medicare, then you would continue to roll up an invoice or costs unless you had either a Medicare supplement plan or a Medicare Advantage plan. One or the other of those types of plans would cap that for you, but Medicare in and of itself does not. Also, Medicare does not cover you outside of the United States. So if you're traveling in Europe and you become sick and all you have is A and B of Medicare, Medicare does not cover you outside of the United States. The different plans that I keep speaking about, however, will. Medicare also does not cover prescription drugs. This is a little misleading because Part D, which is the prescription piece, is called Medicare Part B, D rather, as in David. So most people think it's supplied by the federal government. It isn't. It's supplied by private carriers. In the case of Massachusetts, this year there's 25 different plans that offer Part D coverage. Next year it's increasing by 27 plans will cover you in Massachusetts. And using Medicare as primary insurance allows you to use any primary doctors or specialists who accept Medicare. So you can go to a specialist without a referral, and you can access a hospital of your choice. The reason being is that all hospitals take Medicare. Not all doctors will take Medicare. For example, in Massachusetts, 96%, virtually all of them, but not all of them, 96% of the doctors accept Medicare. The 4% who don't are primarily comprised of some sort of mental health therapist. So they're not particularly enamored with their compensation from Medicare. So, the 4% who don't take Medicare are usually some sort of mental health professional. There's two parts of Medicare. First part is hospital insurance. This covers hospital and skilled nursing facility stays, some home health, and hospice care. One thing that we need to differentiate here is that, it talks about nursing facility stays. That does not mean if you're going to a nursing home for custodial care that Medicare will cover you. They won't. It does mean you can go there if it's part of a rehab stint. So if you, for example, break a hip, you wind up in the hospital, and you're there for at least 3 midnights, it's unusual, but you have to be there 3 midnights, are subsequently admitted to a nursing home for rehab, that's covered by Medicare. You need to be recuperating. You need to be able to be getting better. If you're there for custodial care in a nursing home, and you'll be there for the rest of your life, Medicare does not cover that. That's covered by long-term care insurance. The premium for most people for Part A is 0. And the thing that you have to have done in order to qualify that is, in Medicare speak, you have had to have worked 40 calendar quarters. In normal English, 10 years. So either you had to have done that, or you had to have a spouse or a divorced spouse even, who did work those 10 years. And the Part A deductible this year is around $1,400. Next year it's going to probably be a little bit more. Now we're past October 15th, but as I'm talking to you today on the 19th of October, I do not know what the Part A deductible is going to be. If history is any way of learning, I would say somewhere around $1,435 is what it will be. But what that means is that if you have Part A and Part B of Medicare, you're admitted to the hospital, that's all you have. Again, you don't have either the supplement or the Advantage plan. Then the moment you're rolled in that door, you owe Medicare a deductible in excess of $1,400. Now, the Medicare Medicare supplement plans are called Medigap plans. So they fill in the gaps left by Medicare. This is one of the most significant gaps in Medicare. So what are you paying for your Part A deductible? Now, the interesting thing is that deductible is not an annual deductible. You don't pay it once and you're done for the year. You can incur that deductible multiple times a year because the deductible is reset once you've been discharged from the hospital for 60 days or more. So technically you could be admitted to the hospital in January, readmitted in April, and incur that deductible both times. Second part of Medicare is Part B. Now this one covers most of your medically necessary services, some preventive services, most especially doctor visits, specialist visits, lab tests, outpatient care, and durable medical equipment. So on the one piece covers you in the hospitals, and the other piece covers you anything to do with the doctors, tests, and so forth. Now, unlike Part A, where you had no premium, Part B incurs a premium. Most people, in fact 70% of the people in the country, pay $144.60 per month for Medicare Part B this year. Next year, it's going to go up. What it's going to go up to, I don't know yet. My guess is somewhere around $150 a month. Interesting thing has been for a number of years, Part B has become means tested. What that means essentially is that it's no longer a standard fee. there's a range. As I mentioned, most people pay $144.60. Others can pay as much as $491.60, virtually $500. So you've got a range there of around $150 to a high of $500 for the same benefit. The thinking was, and what was introduced a number of years ago, is that people with what they've referred to as high income or high wage earners should be charged more because they can afford it. And that was one of the things that Medicare came up with in an effort to keep it so that it's solvent. So people who can afford to pay more are charged more. This is a relatively new development. You can pay as much as almost $500 for Part B. Part B can be deferred with no penalty if equivalent coverage is supplied through an employer health group, either through yourself because you're working there, or you have a spouse who's working there and you're getting your coverage through your spouse. This is one of the things I get the most questions about. So people are turning 65, they've read, and usually it's reading that prompts this, that they'll be penalized if they don't apply for Part B as soon as they turn 65. The reality of it is, if they have alternative creditable, and that's the key word, creditable coverage, then they will not be charged a penalty. Creditable is if your drug coverage is at least as good as or better than the actuarial equivalent of the Medicare Part D. So it's kind of a convoluted formula, but as just a rule of thumb, the only plans that I've found that typically don't get designated as quote unquote creditable, you can't see my other hand, quote unquote creditable, is those that have an individual deductible of more than $3,000. So if you've got a plan that's got a health savings account and you've got a high deductible plan, then those are the ones that you should look at as, are they creditable or not? If you don't have a high deductible, you can be virtually guaranteed that it is creditable. Now, on Part B, there is an annual deductible. So one time a year. This year, it's $198. Next year, once again, I don't know yet. If I had to guess, I'd say it would be somewhere around $205 next year. The big cost that people are exposed to under Part B is coinsurance. So if somebody has a doctor visit, they're responsible for coinsurance of 20%. Now, that seems like a small number, 20%. But I remind people that when I was 50, I had a ruptured appendix. When I went to the hospital, finally, the surgeon's bill was $25,000. So 20% of $25,000 is $5,000. So it can be something of substance. These are the income benchmarks. So you high wage earners need to pay special attention to this. So if somebody has an individual 2 years ago, because the government always looks back 2 years. So if you were to retire in 2020, they would be looking at your 2018 tax return. And if you were single in 2018 and had income of 80, it's actually modified adjusted gross income. So that's the key term. It's what you made minus some business expenses. Of $87,000 or less, the government would charge you that lowest benchmark of $144.60. If you were half of a couple and you had twice that income, or $174,000 or less, same thing applies. They charge you $144.60. However, you go to the next income bracket up, and you're talking about $87,000 to $109,000, again, as a single taxpayer, or $174,000 to $218,000. Now, all of a sudden, the $144.60 gets jumped to $202.40, And now they start charging you an income assessment. They call it an IRMA for your Part D, which is the prescription piece. So the government says essentially, we subsidize Part D coverage. So the more people make, the less they need that subsidy. So the more money we're essentially going to claw back. We're going to take it back because they don't need it. And you can go all the way down to the bottom, and you'll see for income as a single taxpayer in excess of essentially $500,000, $500,000 to $750,000 for a couple. Now all of a sudden they're charging you the $491.60 for Part B and $76.40. It's up here. This is not as easy as it looks for Part D. You have to pay the two of them. So you can see you're somewhere around $560 for you higher wage earners. Now, if you look down at the very bottom of the page, you can barely see it, but right there, it's talking about Social Security form number 44. Remember that, 44. I'm trying to think of who was number 44. I think Leroy Kelly for the Cleveland Browns years ago was number 44. So think of 44, and that form can be filed with the federal government if you're retiring. Say next year, you're retiring in February. Now they're going to be, because it's at that point 2021, they're going to look at your 2019 tax return. And at that point, you were working. So fast forward to 2021, you're retiring in February. You're working for maybe less than 2 months of the year. It stands to reason your income in 2021 would be substantially less than it was 2 years prior. So that you can file that form, SSA number 44, and you can contest the amount that the government will want to charge you. Now the government was going to find out about your reduced income at some point, but that some point is 2023 when they look back at 2021. You don't want to be paying that higher rate for 2 years. You want to be paying the lower rate as soon as you qualify for the lower rate. And if you could substantiate the fact that your income has been substantially reduced due to your retirement, then they will charge you the lesser of the two amounts. So when people are eligible for Medicare, that means that they have Part A and Part B of Medicare. This is a sample of a card that has both Part A and Part B of Medicare. And I know that because there's an effective date right there of March 1st, 2016, after Part A and also after Part B. It's not uncommon that people would have Part A and Part B the same day. That happens a lot when they turn 65 and they retire, or they turn 65 and they've already retired. Where you get a different date is a lot of times people will be working for a large employer. They don't have a health savings account. They're turning 65. They elect Part A. They elect Part A only. That's the one that doesn't cost anything. They elect Part B subsequently at a later date when they're retiring. And now they want to go on Medicare. They're no longer going to be staying on their employer's plan. You need to get your signing up of Medicare at the right time in order to avoid any penalties. Now, enrolling in Medicare. You're automatically enrolled in A and B of Medicare if you're collecting Social Security before the age of 65. So I mentioned earlier, it's not so prevalent nowadays, but it used to be that a lot of people would take Social Security when they were turning 62. Nowadays, people typically wait until they're 100% vested in Social Security, and that's 66 and change. I believe it's 66 and 2 months, people retiring now. And over the years, that age will go up. But so you get people a lot of times who hit 65, they have not been taking Social Security, so they are not automatically enrolled in Part A and B. And if they want to enroll in A and or B, they have to initiate the process. Used to be until we hit 2020, a lot of people would go to the Social Security office nearest them. Of course, those offices now are closed due to COVID-19, but you can call Social Security, and I'm going to go over those numbers later, and or you can go online to Social Security and apply just for Part A, or you can apply for both. If you have received Social Security disability payments for at least 24 months, 2 years, then you are automatically enrolled in A and B of Medicare. You're not automatically enrolled in A and B of Medicare if you're not receiving Social Security. So when people are turning 65, they have a 7-month window to join Social Security, to join A and or A and B of Medicare. They have 3 months before the month in which they turn 65. They have the month in which they turn 65, and they have 3 months thereafter. So there's the 3 months, the 1 month, and then another 3 months. That's that 7-month window. And once that's gone forever. That's called your initial election period. And once that 7-month window has expired, it never comes back. You get other election periods that you can join Medicare. The next most popular one is called a special election period, an SEP. A special election period comes along when somebody is retiring, they're leaving or losing their employer group coverage, and they're going on Medicare. Somebody who is in a large company, and when I say large, I mean 20 or more employees, typically does not need to join Part B. And if you have end-stage renal disease, contact Social Security about the A and B because the rules there are a little different. So these are the enrollment periods that Medicare has available. One is, as I mentioned earlier, going on right now. That's the annual election period. They call it AEP. Sometimes they call it the annual enrollment period. That's open to everybody who's already on a Medicare plan. Starts October 15th, so it just started, and runs until December 7th, Pearl Harbor Day. I think they did that specifically for baby boomers because we all know that December 7th was Pearl Harbor Day, but our kids have no clue. They have no idea. My daughter was married on December 7th. She had no idea. Anyhow, so that's the first one that then comes along is your initial enrollment period. I talked about that. That's the 7-month window. The next one is a special enrollment period. Usually that's a result of you're losing employer group coverage. Sometimes it can be you're already on Medicare, but you move out of the service area. So you move from Massachusetts to Florida, for example. You would have a special election period. There are a whole bunch of other reasons, but primarily I run into people are either turning 65, so they have that initial enrollment period, or they're retiring. Now, say you miss your initial election period, and you also miss your special election period. Then you have to wait for the general enrollment period, and inevitably, if you're waiting for your general enrollment period, now you're being penalized because you missed your initial enrollment period. And that starts January 1st, runs until March 31st, but it doesn't even become effective until July 1st. So you can be going months without Medicare coverage. You've got to take coverage through an individual plan, very expensive, and then to add insult to injury, once you enroll in July 1st, government's going to penalize you. So if that's the thing that I keep referring to, you know, you got to make sure that you pay attention to most especially the special election period. So once you are eligible for Medicare because you're turning 65, you essentially have 4 options. First option is if you're working for an employer with 20 or more employees, you can elect Part A and decline Part B. So you take Part A only. Again, no charge for that. If you have a health savings account, you don't want to do that. we'll talk about that. But if you have a health savings account, if you've got a high deductible health plan, then you want to defer both Part A and Part B of Medicare. Second option is you can take A and B of Medicare. That's all you've got. You get A and B. Maybe you get a standalone Part D plan to cover your prescriptions as well. Maybe you get your prescriptions at the VA. So maybe you're a veteran and you have access to the VA. And frankly, the only time that I run, mostly the only time that I run across somebody that has only A and B of Medicare, they're usually a low-income veteran. So they're getting their medical coverage at the VA, they're getting their prescriptions at the VA, so they feel as if they don't need Part A and Part B of Medicare. I tell them, though, that if they have, or they only have a Part A and Part B of Medicare, when I run across somebody like that, I always suggest to them that they take a zero premium, just like it sounds, Medicare Advantage plan, because that way they can avoid having to pay the deductible if they're ever hospitalized on an emergency basis. So that deductible, we mentioned earlier, was about $1,400. Yes, you will be charged a copayment if you're admitted on an emergency basis to a hospital on a Medicare Advantage plan, but it's nowhere near that $1,400. What most people do is they take either option 3, which is a Medicare Advantage plan, also called Part C, also called Medicare Part C, or they take option 4, which is a Medicare Supplement plan, also called a Medigap plan. So both of those plans are administered by private insurance companies. You don't get them through the federal government. With Part C, the Medicare Advantage plans, you have the drug plan, Part D, built right into the plan itself. On the Medicare Supplement plan, you take a standalone, in other words, all by itself, Part D plan to cover your prescriptions, because no supplement plan also covers prescriptions. So you have to take that separate plan. I think this slide is virtually the most important slide in the deck. So this is the Medicare plan choice highlight. So what differentiates them one from the other? And I've listed them in order of risk. So the more risk, the higher it is up on the page. So this is the highest one right here. And then it gets lower and lower as you get down to the bottom. More risk, less risk. So the first risk is you just have A and B of Medicare. Kind of already talked about that. Medicare Advantage plan, Part C, is, at this point I usually talk about what I'm on personally and what is my wife on personally, because I find that people learn better from a story. So my wife is on a Medicare Advantage plan. She took that in 2012 when we were both 65. So we both turned 65. I'm a little older than she is, but by about 6 months. She took a Medicare Advantage HMO, and the prescriptions were built right into the plan. So that's called an MA, Medicare Advantage PD plan, MAPD. So that's telling you you've got the Medicare Advantage plan and you've got the Part D piece built right into it. And her premium was $40 a month. So that's a great premium. I mean, we were just done, when she was 64, we were paying about $900 a month for her health insurance, including prescriptions. Then she turned eligible for Medicare. Yes, we did have to pay for Part B to the federal government, but we paid only $40 to the health plan for a plan that included her medical coverage and her prescription coverage. Now, on a Medicare Advantage plan, you pay a copayment for everything. So when she would go to the primary care doctor, that copayment was $25. When she would get a referral from her primary care physician to go to a specialist, that copay was $40. And on those types of plans, the highest copayment is always for a hospitalization. So in that plan back in 2012, it cost her, or would have cost her, about $300 a day for a maximum of 5 days if she were to have been hospitalized. So think of that almost like if, in a restaurant term, that's an a la carte menu. You're paying for everything separately. Doesn't pay that much for a primary care physician, but pays quite a bit more for a hospitalization. Has got to get referrals. Those plans are very competitive. So you'll notice that if you're already over 65 and you're getting literature right now because it's Medicare open enrollment and you're getting it from the health plans, I can bet that 90% of that literature is from Medicare Advantage plans. And the reason for that is that's the plan that they make their highest profit on. So they want to sell that plan, and the one that gets the most in terms of membership can diversify their risk the greatest, and they typically are the most profitable plan. But they also add benefits, so they want to induce you to join their plan. They'll add things like vision. Now, when I say vision, I don't mean so they'll cover you if you have glaucoma or anything else that's related to the eyes. I mean eyeglasses. So they'll cover eyeglasses, they'll cover some dental benefits. Those are examples of things that Medicare itself does not cover, but these plans do cover in order to induce you to join their plans. So just in terms of a recap, so she has to take a plan that's got a primary care physician. So the first thing you need to do if you're considering that type of plan is ask your primary care doctor, do you take any Medicare Advantage plans? Stressing that word, Advantage. And in order to take an Advantage plan, your PCP has to have a contract with that Advantage plan. So it's not just, yeah, I'd like to take that. It's they've got to, their doctor group has got to have a contract with a Medicare Advantage plan in order for them to take it. And then you would see that doctor for whatever the copayment is. The premium can be as low as $0. So in subsequent years, 2 years ago, my wife switched from the HMO that was $40 a year to a PPO, a preferred provider organization, that gives her access to more doctors that had a $0 premium. Now the interesting thing about it was we didn't switch her to the PPO because of the $0 premium. We switched her to the PPO because that PPO gave her up to $1,000 reimbursement per year for dental. So the reason we took the Medicare Advantage plan in the first place is my wife is very healthy, or she has been, knock on wood. So she didn't take any prescriptions in 2012. She still doesn't take any prescriptions. Both of her parents live to be 95. She goes to a couple of specialists a year just for checkups, just to make sure everything is the way it's supposed to be. And so her medical expenses are very low. And so we figured her co-payments were going to be also relatively low because she wasn't accessing a lot of services. But she did go to the dentist a lot, and she did have things like root canals and bridges and so forth. So for me, $1,000 reimbursement per year was like manna from heaven. So she took that 2 years ago. She's going to stay on that plan for 2012. But again, low cost. I'm going to skip over this core plan. And the reason I'm going to skip over it is that very few people take it. What they take to this year is the Sup 1A, which is the supplement plan that covers everything that's medically necessary. The only thing that you're responsible for cost, is the Part B deductible. So I mentioned earlier, in this year, 2020, the Part B deductible is $198. So it's going to go up in 2021, I'm guessing, to about $205. I don't know that, but just in your own mind, think, $200. I can ballpark that. So you've got the $200 that you're responsible for. That's for Part B, which is doctors. So in your first doctor visit or your first test, you probably get charged that $198, and then that's it for the year. Now the Sup 1A plan, again for budgetary purposes, that's what I'm on. I'm on the Sup 1A. You can figure about $160 per member per month. So you can see there's a big difference in cost. On the one, you had either $40 or zero, and on mine, you're looking at about $160 the first year. I'll also add for the Medicare Advantage plan that I want to make sure that people understand they have to get a referral. That's most especially true for the HMOs. But on my plan, I don't need to get a referral. I can go to any doctor in the country who takes Medicare. I can go to any specialist without having to get a referral as long as they take Medicare. And as I mentioned earlier, 96% of all the doctors in Massachusetts take Medicare. So I can be pretty much assured that my doctors are going to take Medicare. So I don't need a referral. I did that specifically because I wanted access to the world-renowned specialists in Boston. I didn't want a primary care physician telling me who I could or could not see. And the reason that was especially important to me is I had cancer when I was 55. So once I was 55, in my own mind, I was no longer immortal, and I wanted to make absolutely certain when I hit Medicare eligibility that I wanted that access to doctors. Had that not happened to me, I probably would have taken a Medicare Advantage plan. A lot of people who start out 65, they're relatively young, certainly in Medicare terms, they're as young as it gets. If they're relatively healthy, it's a good idea to, at the very least, look at a Medicare Advantage plan. A Medicare Advantage plan, so you know, don't travel as well, especially domestically, as a supplement plan. So when I meet somebody and they're a quote-unquote snowbird, I typically recommend that they go on a supplement plan, because that way Medicare is primary, they can use it in Massachusetts, they can use it in Florida, or wherever it is they go. Now on Medicare supplement plans, they cover everything that's medically necessary, but they don't cover prescriptions. So anyone that's on a Medicare supplement plan has to take a separate, called standalone, Part D plan to cover their prescriptions. In Massachusetts next year, there's 27 plans. So then the question is, okay, what's the best plan for me? The premium for those plans range dramatically. The cheapest one on the market next year is $7.20 a month. Not bad. The most expensive one on the market next year is $138 a month. Big difference. So the question then becomes, okay, of those 27, which one fits me best? And that's why I mentioned early on, Kathy and I look at people's prescriptions. We get a copy of their prescriptions, a list, including dosages and monthly quantities. We go on the Medicare website, and that's important because that's a neutral site. That's not some plan that's kind of spinning the result in their favor. It's the federal government that's saying, matter-of-factly, you know, this is how these particular drug plans will treat your individual drugs. So you have these lined up by virtue of cost. You also have them aligned by risk. So the higher the risk, the higher the cost, or the lower the cost rather. So it's an inverse relationship. The higher the risk, the lower the wait a minute, let me rephrase that. So mine has the lowest risk, but it's the highest cost, okay? I'm paying to lower my risk. My wife is taking on more risk because she's exposed to more copays, a lot more copays than I am, but she's paying a lot less. So that works out well for somebody who's not going to the doctor as much. For somebody that takes on less risk and is willing to pay for it, they have more access to doctors. And really, that's the key differentiator between the two types of plans, is which one gives you the greatest access to doctors. So this is the prescription drug coverage under Medicare. A lot of times when you see the prescription drug coverage talked about, what they look at is different graphs. I find that that was confusing for a lot of people. So I like to break it down into this 4 stages. There's the first stage is there's the deductible. So if somebody's got a Part D plan, then that plan most likely has a deductible, and they are allowed to have a deductible this year that is as high as $435. Next year it's $445. So that means that, for example, I have a drug plan. The drug plan has that $435 deductible this year. My prescriptions are all generics. The generics do not trigger that deductible. And by that I mean that as long as I'm taking those generics, I don't have to pay that $435 deductible. If at some point during this year, my doctor were to prescribe me a prescription that was a tier 3, 4, or 5, in other words, a brand name prescription, that would trigger the deductible. So people usually think when they see a deductible, I've got to pay that up front. You know, like in most health plans, when you have a deductible, you pay that up front. That's not true for the drug plans. So just because you have a deductible does not mean that you will be paying that. You won't know that until you've had your prescriptions analyzed. And that's what we do. We tell you, well, you're going to be paying the deductible because you take this one brand name that triggers that deductible. The next stage is your initial coverage period, where you have a set copayment. That's very similar to the employer group plan that you may very well be on now. So your employer group plans have a copayment that remains stationary throughout the course of the year. Your stage 2, the initial coverage period under Part D, is very similar to that. But now it's different because the government gives you essentially about $4,000 that you get to play with, if you will. So they say, okay, you've got $4,000 before you enter stage 3, which is called the coverage gap or the donut hole. And that's what people are afraid of. People are afraid of, are my drugs going to get me into stage 3 or the coverage gap or the donut hole, as some people refer to it. And in order to get there, you have to have had in 2020 used up $4,020 of retail costs of the prescriptions. People oftentimes will say to me, well, there's no way I'll ever spend $4,000 in prescriptions, so I'm not going to hit the coverage gap. That's not what that means. That means if the retail cost of your prescriptions, so you may be paying a $5 copayment for a drug that has a retail cost of $150. It's not the lower amount that gets counted towards the $4,000. It's the actual retail cost of $150. And some drugs have a retail cost that's way higher than that. So people can get into the coverage gap pretty quickly. Most people, I find, get into, if they're going to get into it at all, do so around this time of year. So, you know, they've used up the $4,000 that was allocated to them. Now they're in the coverage gap. And when they get in the coverage gap, all of a sudden they're paying a higher amount because they're no longer paying that set copayment that was in stage 2. Now they're paying 25% of the actual retail cost. So in the example that I used earlier, so let's say they were paying a $10 copay, but the actual retail cost was $150. So 25% of $150 is $37.50. So the jump there was from $15 to $37.50. The jump for people who are on very expensive prescriptions is much more than that. And then once they're in the coverage gap, they're in there for quite a bit of time because then in order to get into the last phase, it's over $6,000 that actually does come out of your pocket. That's not, we're not talking about retail cost anymore. We're talking about actual money that you've paid in co-payments. Once that reaches over $6,000, now the cost comes way down. That's for people that are on horrifically expensive prescriptions. And so that you know, about only a third of the people nationally hit the coverage gap. So that means 2/3 of the people don't hit it. So most of the people who are worrying about hitting the coverage gap are never going to hit it. So this sort of is a recap on the Part D phase. So there's 4 phases. The best one depends on what prescriptions you take. So the bottom line matters. You know, that government website will tell you how much your projected cost is for the rest of the year. So when I'm doing projections now, I'm doing them for the whole year, January through December. Once we get to, say, April, I can only see the balance of the year after that, or any other time after January. I can see the next month to the end of the year. So if I'm doing this report in April, I can see from the 1st of May through December. Right now, I can see the entirety of 2021. So it's a nice time to be doing those types of things. You know, there are different ways you can get your prescriptions. You can get them as a standalone plan, or you can get them included with a Medicare Advantage plan. That's where a lot of people will get it. They'll get it through their Medicare Advantage plan. The analysis on the drug plan is very reassuring for a lot of people, because they think, oh my God, this is going to cost me a fortune. Sometimes, unfortunately, they're right. You know, this is the time of year when I look at people's prescriptions. I get people from time to time when, frankly, I always feel badly. They have a prescription that's just costing them all sorts of money. Even for somebody who can afford it, you know, spending that kind of money on prescriptions is a shame. But, you know, once you've had that analysis done, you know for certain it's no longer, gee, I think maybe I know how much this is going to cost me. So getting started, usually it's because, again, you're turning 65, or more and more nowadays, it's because you're over 65, but you've decided to retire. Frankly, unfortunately, one of the things that I found this year is it's not that you've decided to retire, it's that your employer has decided, you know, with COVID-19, we've got some real issues here, and we need to cut back on our personnel. And unfortunately, that tends to hit older people more than it hits younger people, because those are the people that are costing the employer more, so they can save more by cutting that person. The last point is a caveat. Do not stay on COBRA for more than 8 months. Okay, there are severe ramifications for that. I tend to take it a step further. I look at it very conservatively. I tell people not to stay on COBRA for more than 2 months, because every now and then I find a problem with people who have stayed on COBRA for more than 2 months. So rather than, I would just tell you, don't stay on COBRA for more than 2 months. If you want to talk about it, terrific. I'd be pleased to discuss it with you. We could find that, well, your circumstances are such that you could stay on it for 8 months. But I want you to assume going forward, I can't be on COBRA for more than 2 months. I'd rather you be safe than sorry. And when you're looking at what kind of a plan that you want to ultimately join, access to certain providers is very key to some people. Some people don't really care. They say, you know, whatever it is, doesn't matter to me, as long as I go to the same hospital or whatever. Other people want very specific specialists. They want very specific access. The Medicare Advantage plan is going to give you lower costs. It's going to give you some additional benefits, but it is going to restrict your access to doctors in some way. So the rest of it is just, I'm talking about myself and Kathy. If you'd like to get in contact with us, if you'd like to look at what your options are, we're pleased to help you. We're delighted to be working with RERCNA, and we're pleased to be a part of that team that can help bring services that you may need to add quality to your life. So that's it. Those are the important Medicare numbers and Social Security numbers for you to call, and thank you for your time this afternoon. Thank you very much.
Peter, thanks a lot. I'm gonna mask up for this.
Okay.
But I just want to clarify a few things. It's important. You can see why we call it the maze, or why he has a maze on his website. This whole process of trying to figure out how Medicare works is a touch and go. So you do it all the time, and what I tell a lot of people that I work with in the long-term care, or the nursing home, or the healthcare area, I do it all the time. They only do it once or twice in their life.
Right.
So it's important. I know my mother's 90 years old, and I had to help her through the Medicare
Yep.
programs. And I remember you work backwards. You go, you don't.
Yeah.
Say, most people, I've run into clients that say to me, "Well, I looked at the Medicare. I chose this program. I was thrilled. Then I had to go to the doctors, and the doctor said they don't cover me."
Yeah.
Because it's not their program. So it's so important to work backwards.
Right.
It's so important to
Absolutely.
call your doctor and say, "Hey, I'm going to change my health insurance, or I'm going on Medicare. What do you offer? What plans do you take? What drugs what medication I should say, do I have at my disposal? And what Part D covers that? That's huge. And also if I'm traveling, my wife and I, we travel all the time.
Yeah.
When I get to 65, I'm not there yet, but when I get there, I'll need somebody
I
like
didn't
you.
think you were there yet.
Thank you. You can't. Anyway, the mask helps. But anyway, when we get to that point, we're going to need somebody like you, because it's hard to figure out. And I've been in the insurance world for 17 years, and this is an area where I started to look at,
Yeah.
and I go, oh my God, it's very complicated, and
It
it's a dismal thing. Can I just go back a couple of slides?
Sure. Absolutely.
I just want to mention right here, you're welcome to go to RERCNA.com and information, and right there, and you can call us, and we can connect you with Peter or Kathy, or you can call Peter or Kathy directly. He gave you their numbers. But one thing I want to mention is the Retirement Education Center is about informing people, educating people, and giving them access to professionals that can help them out. We don't charge the end user. It's a wonderful thing, and we have people that we've vetted and have joined our organization because they stand for what we represent. So Peter does, and his organization does. So we're here to let you guys know that he's a great source, ton of information, and feel free to call us or reach out to us, and we're there to help you out. All right, thank you very much,
Thank you.
and Peter, thank you very much.
Thank you. It's a pleasure.
And, greatly appreciate it. Have a nice day, everybody.
Thank
Take
you.
care.